Well, welcome back, everyone. Happy New Year to you. Christina, Mitz, and myself. We're on a split screen today, partly due to the weather and all those other things in our world at the minute. So we can still do questions, but it's a fraction more delayed and so on. So be patient with us, ask your questions, and we'll try to get to them as best we can. So I hope everybody's ready for a very good year in 2021. It's going to be an interesting, challenging year for almost all of us, and I don't have to say why. Today, I thought we would talk about stroke and COVID because COVID can increase the frequency of stroke up to 8 times, is what some of the numbers are saying, and we'll go into why that's the case. And stroke is, of course, a full chapter in the book, and it ties in a bit with the previous two discussions we had. One was on migraine headache, because migraine headache is a strong correlation with stroke, unfortunately, having had migraines for 35 years. And also, it's a significant correlation of stroke with MS. And so that is a bit interesting too. And now that I've had personal experience with COVID, it's another piece that we can chat about and talk about. So stroke itself, of course, as you're all aware, is also called cerebrovascular accident. It's a blood vessel problem. Almost all of us think of stroke as being primarily arterial, or the arteries, and in reality, 2 or 3% of stroke is also venous. So any of you that have the thinking about CCSVI, or cardiovascular, cerebrovascular vascular changes, will be interested in the same issues, okay? And I want to address, with the help of Christina, some of the things that we can do to minimize our risk of stroke at any time or in the whole, time with COVID, because it seems to be with us now for a while. So stroke can happen at any time, but now with COVID, it's happening even in people in their 30s and 40s, which is uncommon because one of the risk factors for stroke is age. And of course, stroke also happens in the very young, and some of you will know that. It's a secondary risk factor in some women when they go on an oral contraceptive pill, because there's a change in the clotability of the blood. And so sometimes when very young people have a stroke, especially women, one of the first questions should be, is that one of the reasons? Because it's a factor within it. And often there's a family history that goes along with that. And so those people, might well be enthused about another method of contraception in that method. The stroke factor, I'm lucky enough, as I talk a little bit about in the book, I was part of a stroke research center at the University of Saskatchewan in Saskatoon in the 90s. We were given $1 million grant from Heart and Stroke Canada to research stroke, and I was doing that with a lot of people, and one of my best mentors in stroke, of course, was Ashfaq Schwabe, who's works still at the University of Alberta, and he's one of the stroke neurologists, experts across the country. So much of my teaching early on was from him. A lot of the other has happened, of course, in preparation to write my book. You can see it above you there in the Spanish and English tradition, solving the brain puzzle, because we need to talk about stroke. Why? It's really common, and yet we don't offer much to it in regular medicine. We can talk about the urgency factor. If you can rush in for care within 3 to 4 hours, then they may give you something to dissolve stroke once they confirm it isn't a bleeding stroke, which is around 10% of strokes overall. And of course, you don't want to give an anti-clotting factor to a bleeding stroke. You want them to see a neurosurgeon right away, and it's almost immediate, life-threatening if it's major, because it can be very comprehensive and take away the breathing and so on. So the frequency of stroke, I think it's something like 800,000 a year in the US, and 3/4 of those, or 600,000, will be first-time strokes. So everyone should be aware of the risk of stroke. I think it's always increased if you have an infection, whether that's a bacterial infection or a virus infection, okay? So they did an interesting study in 2016 to 18 with the flu and the frequency of strokes, and it was around 0.2%, which is above the regular average amount. And then with COVID, in the same time frame with having the infection of COVID virus, then it was 1.6, so nearly 8 times, so dramatically increased. So what are the risk factors of stroke? Well, the important piece to remember, and if I miss one of these, let me know, please, Christina, because I'm sure I'll miss some. But the risk factors of stroke are almost identical to that of heart disease, okay? So if you've got hypertension, and of course, almost all of these are correlated to concern with COVID aggravation too, right? So hypertension, heart disease of any type, including heart failure, particularly, as well as any chronic illness like obesity. One of the things I don't want anybody to do is be smoking, because it's a huge factor and it's the most controllable factor of all. Stop smoking. Then other features of another chronic illness. So they're increased in people with an autoimmune disease like lupus or...
We lost you, Dr. Code.
Okay, I've faded in and out.
Yep. There you are. You're back again. Okay.
So the biggest factor is what you can do to improve your well-being and reduce your stroke risk. So a healthy, primarily plant-based, but in my world, gluten-free, dairy-free diet, because those reduce the inflammation factor within the body and the gut. And part of those features will be discussed as we go on, because there is influence of those subtle factors, but very changeable or reversible risk factors that we can do as individuals, right from reversing, for example, heart disease and reversing your stroke risk factors in 6 to 12 months by what you put in your mouth. Okay, so that's a big, big deal for us. And, that's talked about not in just the stroke chapter, but other parts of my book, Solving the Brain Puzzle. So I think the next piece might be talking about the acute treatment of stroke. And of course, most of you have heard of that now. We've been doing it for probably 30 years now. If you get urgently to the hospital for a stroke, which is not always done even now, because most people turn over and wait till morning sort of idea. But if you get there in the first 3 hours, sometimes they will give you something to help dissolve the stroke, okay? And that's the premise, that you can help dissolve the stroke, and that improves outcomes in the short term. Unfortunately, we have learned in the last 30 years of doing this, it doesn't work as well or as often as we would like. In some vessels in the brain, it'll work up to 30% of the time, and in some vessels to the brain, it'll only work 10% of the time. So the big factor is what you can do about it.
Well, I think we should almost back up again, because we heard your very sciencey doctor definition of stroke, which
okay, yeah, and fair enough.
Venous and arterial stroke, but can we simplify that even further, which I think would also lead us up to talking about how related to inflammation it is?
Well, sure. And so what would you see as a layperson of yourself or a loved one, someone that you're with at the time of stroke? Well, changes in speech are a huge common one. Sometimes the inability to speak, but sometimes even just stuttering or finding trouble with words. Paresis, or lack of movement of one side, or sometimes less than that, maybe just a hand is affected. So even when someone goes in with symptoms of multiple sclerosis, the biggest thing they're trying to confirm is this a stroke or is this MS in early forms? So those are some of the features. I've missed one or two. What other things might we see in a layperson stroke that you're thinking?
Actually, the diagram I posted on your Facebook page was really, really helpful for that. And it turns out there's actually differences for men and women. Mm-hmm. So women are more likely to experience fatigue, nausea, or vomiting. There's the drooping face, arm weakness,
Yeah.
speech difficulty, vision problems, trouble walking, and severe headaches. Those things are kind of all shared, but then for women, women might experience general weakness, disorientation or confusion, and the fatigue and nausea.
Yeah. So, and that's an important differentiation too, because one of the things that happens when you get a brain injury, whether it's a concussion from a blow or it's a stroke, often we get huge fatigue because it's one of the body's protective mechanisms make you feel a sensation of fatigue. And so then you've got to listen because this is a new onset, something has happened in the brain. And on that list needs to be stroke. And a corollary to that is if someone gets a head injury of any degree, even if they're not unconscious or don't see stars and so on, you need to take them out of the football game or the hockey game or the soccer game because that is a very major signal of concussion or traumatic brain injury. Okay, so that can mimic stroke or vice versa. So usually we've got age on our side, and people in their 70s and 80s aren't out playing hockey too often. Oh, I've got friends that are, so more power to them to work with it that way. And the other thing, it's very important because women don't always think or realize that this sudden onset of fatigue or vomiting might be a stroke. Just as, the chest pain is somewhat different in men and women for heart attacks as well. So it's important to know those and have an understanding, and you behooves you to know that, just as the chart would be useful for people to look at, because your family doctor may not be familiar with those issues, particularly the difference that's in women. And yet women are very much prone to strokes, especially in the postmenopausal time when the risk of heart attacks and everything else goes up. It starts to equilibrate to men. Yeah.
And then, correct me if I'm wrong, but the basic mechanism for stroke is the brain is starving.
The brain is starving for oxygen, or to back that up a little bit, blood flow. Okay. So it becomes in the bleeding stroke, of course, and I've got a major case of bleeding stroke I talk about in the chapter in the book, because it's often very much bigger and faster. Okay. But when it's an embolic, or meaning a particulate piece of matter, usually a blood clot component, is triggering the stroke, it's blockage of a blood vessel. And when you block that blood vessel, you get reduced flow to that entire area. But be reassured, and this is a really important thing because this ties into how you might treat a stroke, unlike we do kind of in regular medicine. In regular medicine, we kind of have this concept that all the areas supplied by that blood vessel immediately will tend to die. In reality, virtually none of the brain cells die, but they're short of blood flow and secondarily short of oxygen, and they become idle or sleeping neurons. And so that's a key factor because we can reverse that potentially and allow recovery. Whenever we talk about stroke, we always talk about the initial blood flow region around the stroke, and then we talk about part of that region will get some blood flow from other regions because there's an overlap, or a so-called watershed area. So that's the reason that if someone has a stroke, ideally you would put them on extra oxygen, even by mask, or if you have to, nasal prongs at 3 to 5 liters a minute, because that will raise the oxygen slightly and it will reduce the injury somewhat. Okay, so any of these are useful pieces. So going on the pulse oximeter, is if it's up there at 98, 99, doesn't necessarily mean that that part of the brain that's got a blocked blood vessel is up there that high. So that's why you would put it on despite the pulse oximeter when you have a stroke or a possible stroke, because there's virtually no downside to that. But it does give you a clue as to what we might talk about how to treat stroke as we move further on. So that kind of fit together?
Yeah, exactly. That's exactly what I was looking for. There are a couple more root cause things we can talk about that would lead up to stroke. And so I think the main one that most of us know about is the the plaque on the veins, the arteries in the veins, and that plaque is delivered there basically in response to inflammation. Is that right?
Well, sure. Inflammation tends to come in the vessels first. And the inflammation is really important too, because inflammation, one of the four components of inflammation, you hit your thumb with a hammer, you get redness, swelling, heat, and pain or loss of function. But the same happens in the blood vessel. So the key one to think about, we don't tend to get pain in the blood vessel unless it's completely blocked in a peripheral area, and then we might get ischemic pain, much like a heart attack pain. But the other feature about it is the swelling of a blood vessel reduces the flow. So I put my fingers up like this because I always like to talk about if you cut the diameter or size, radius in half of that blood vessel, your flow goes down to 1/16. Okay, and so that's why the inflammation of whatever is triggering it, whether it's a viral infection or a chronic illness, any of those features, you get inflammation. So you get narrowing of the vessel. Okay, the narrowing vessel, less flow. So anytime you can reverse that inflammation, then you will tend to open up the space and you'll have more flow. And of course, the other way to help that is adding more oxygen to the mix, which can make a difference. And that's why, you know, people worry about the long haul flights in an airplane. You're in relative high altitude, and consequently, if you've got borderline flow to areas, it may become an issue while you're traveling. Yeah. Although that's getting harder to do.
Mm-hmm. And there were a couple interesting ones that were also considered root causes for this inflammation and for stroke and cardiovascular disease. And the number one that I didn't really think about was high estrogen, particularly for women. Insulin resistance, of course, and diabetes. You said smoking. Evidently, potassium deficiency increases your risk for stroke. Lack of sleep or sleep apnea, so anything contributing to sleep apnea, like alcohol intake, lack of vitamin D, and then high cortisol as well. And then I was hoping you could talk about homocysteine.
Well, sure. But so just to touch on the sleep issue, of course, I mean, that's aggravated in obesity. But once people get to their 50s or 60s, that fifth and sixth decade, sleep apnea incidence goes way up. And of course, sleep apnea by definition is a time when you're not breathing. Okay, so that's a huge factor in reducing oxygen flow within the body because you're not getting the oxygen to the lungs temporarily because you're not breathing. And so that's a huge risk factor in the whole mix of things to aggravate it. And sometimes that will be aggravated by a brain illness or problem. And you could include among that COVID as well. So we're trying to work forward on which component that was. Estrogen,
insulin, insulin resistance. And then I was thinking about the specific markers like homocysteine.
Right. So homocysteine, as we've talked about before, and I talk about it several places in the book, is a marker for cardiovascular disease. Okay. And we've talked about before, and we'll talk about again in the future. It's also a marker for early Alzheimer's. Okay. So homocysteine is available in almost any lab in North America around the world because it's a cardiovascular risk factor. Okay. And this is particularly important to us to know our own personal homocysteine, which our family doctor or healthcare practitioner can help us sort out. Because if it's elevated, there's a way to bring it down. There's a way to, lower the homocysteine. And this is primarily B6, B12, and folate. And as a consequence, that's something you can dramatically help. And about 1 in 5 people will be, we call it heterozygous, meaning they've got one of the two genes, so that they need extra amounts of B6, B12, and folate. In fact, I think it's 3 to 4% will be, the homozygote, and so they'll be particularly at risk. And they may even have problems in sleeping as a consequence, and all these other issues. But mostly homocysteine is silent. I used to joke with a friend, and he's an internist, so he was very much up on heart attacks, and he would talk about this young, healthy guy, young, well, there's more young people everywhere today, but he was in his early 50s, say. He's athletic, eats pretty reasonably, and no major cardiovascular risk factors, has a heart attack or a stroke. Well, one thing that needs to be looked at is homocysteine. He may be in that subset or group genetically, and so he has to be extra careful and aware of what he or she eats. I say he because they're typically more recognized and more at risk in the early days, but unfortunately women catch up later on, postmenopausal. So the homocysteine, by bringing it down, knowing what it is, really makes a difference. And if you're having trouble making that happen, then it's time to see a practitioner who is aware of the genetics. Because there's the odd person, they won't deal well with that extra amount of folate. And they'll feel less healthy and less well. So consequently, you then need to go on to someone who's very good at the genetic markers and can help you source those. It's not that difficult to source them anymore. I know that you send people their bloods down to the US to get the genetic testing done. It's pretty tricky to get it done in Canada. Mostly we end up sending it to the US. So I send it often, to Great Plains, for example, but there's other choices, as Christina knows.
Yeah, I've used 23andMe and then just uploaded it to different platforms. And then there's actually a pretty good Canadian one, but I can't remember the name off the top of my head.
Yeah, I'm becoming a little less enthusiastic about 23andMe because I think they've done a large number of people, but I think they also tend to sell their genetic information and you don't have much to do about it. What my big fear is one day, when an insurance company gets hold of your genetic data, now you may get a bigger premium or no insurance at all just because of your genetic personality or individuality. So that's why I like to be a little bit more selective, where I go with that. If it's someone who's, in their 60s, 70s, they're not going to have any children and, all these other risk factors, okay, but you still might have a risk on insurance. So I think, so the other piece is to do, so what typically happens to someone when they have a stroke? So they get to the hospital, they're too late, or else they're checked out and they've decided that they're not going to do the blood thinning piece. Of course, when you do that blood thinning and delivery of TTP or streptokinase or some other thing to dissolve the clot, you can get so-called reperfusion injuries. And in the heart, when this happens, you can get arrhythmias and all these sorts of things. And in the brain, you may get some changes as well. Okay? But they're very good at that. If you're in a hospital center where they're giving that, treatment, then they're good at watching for it. Fair enough. So now that you've got a confirmed stroke, and that means it's lasted at least 24 hours, although sometimes they will say that transient ischemic attacks or TIAs can be up to 48 or occasionally even 72 hours, meaning that they're resolving. But keep one very important thing in mind. Okay, so 3/4 of strokes are fresh or new, but 1/4 are secondary strokes, or the third or fourth, and so on. So even if you're getting TIAs, you need to be really aware and vigilant and make some changes in your supplements, sometimes in your medication, that's up to your doctor, but also in your diet and your approach to things, because your risk is super high of another stroke. And even if the first one only lasted for half a day or 2 days, the next one might seem very permanent. So if you're into that group where it's lasted more than 3 days, now we've got a so-called confirmed blockage to the blood vessel. And what are we going to do? So the very typical treatment in Canada and in the United States and Britain and many parts of the world is you will be admitted to hospital and you'll get 6 weeks of rehabilitation. And the rehabilitation hasn't gone very far or very fast. It's very similar to what it was 15, 20 years ago, unfortunately. So what I would advocate, if you're into that confirmed piece, is try and look for immediate treatments that will make a difference to you And one of those would be hyperbaric oxygen. And if you can't access that, then I would go for normal baric, a non-rebreathing mask, which I've shown to you before, and there's a picture of it in the book, so that you can supply extra oxygen. When you're supplying extra oxygen, it increases the dissolved oxygen in the body with that non-rebreathing mask at, say, 5 liters per minute, and with your home oxygen concentrator, which should have, everybody can hardly buy them now because they have them at home for COVID treatment, to provide that additional oxygen to reduce the area of injury and to increase the likelihood of recovery of that zone. Hyperbaric oxygen is even more dramatic because it increases the dissolved oxygen 12 to 15 times. And we've known since the 1800s that if you increase the circulating oxygen with dissolved oxygen, you can have virtually zero hemoglobin. Okay, so no red cells at all in the blood, but you can still survive on it because it's unable to dissolve as much. But that can't happen without the increased pressures. And the treatment pressures, usually 1.5 to 2 atmospheres. So not a huge amount. Not a huge amount. 1.5 is not too far away from the changes when you go up in an airplane. So those are the features, and those can dramatically make it. It seems that the sweet spot for strokes is 1.75 atmospheres. So not huge because we're already living at 1 atmosphere. Yeah.
Mm-hmm.
You can get some benefit as well from the stroke with photobiomodulation. That's kind of early days. If they put a blood vessel treatment unit in and they can shine it within the brain, they can often reverse things. And now that the newer helmets, like a bicycle helmet, are becoming much more available, I think we'll start to get, some benefit with that. But the core one in my mind is the extra oxygen. And this can affect things months, even years out, and you may get that piece of the brain to recover. So that's why you want to make all the changes you can to reduce the repetitive or recurrent again strokes, secondary strokes, because you're going to work so hard for the rehab side. Now, I didn't say it was going to be easy necessarily, but that you can do it if you really work at it. Yeah.
Okay.
So just as a side thing, we should, you keep me please aware if there's questions coming along. I wanted to now, because we talked in the program, we would talk also about COVID and strokes. COVID, of course, is SARS-CoV-2. It's a coronavirus which came on the scene probably somewhere in the latter half of 2019. Okay, so it's got that number on it now. But became quite dominant and most of the world recognized in February, certainly in March. And, then we've had the big changes since. So COVID-19 is recognized now. One of the tricky features about it is it quite dramatically worsens or increases the hypercoagulable or excess clotting component within people. It makes a really big difference in that. And that's when it's giving all of these it's seemingly unusual anywhere in the body problems. You've probably heard by now of COVID toe or COVID finger. The finger or toe turns black, and that's because the blood vessel is blocked with a clot, quite literally, not unlike the one in diabetes, because diabetes tends to have smaller blood vessels, and clot blocks one off, then all of a sudden things turn black. So that's in the skin showing up. But the same happens in the kidney, so you can get acute kidney failure. It happens in the heart, so you can get heart attacks and arrhythmias and the secondary problems there. It, of course, can happen in the lungs with all the other components of lung injury because, this virus concentrates initially in the upper airway, but it sometimes goes into the lungs. And it, of course, can happen in the brain. All right? Remember, up to 8 times increase in strokes in those that have COVID. And sometimes the presenting feature in a 30-year-old or a 40-year-old is literally a stroke. So you've got to keep it in the back of your mind. recognizing that 80% of people will be virtually asymptomatic with COVID. All right. So it starts to get into a really significant area. If you're getting major new features, keep it in the back of your mind that maybe it's a component. Okay. So the other piece to talk about is how might you approach it to prevent your risk of stroke. So you need to personally know, are you in that 5 or 7% of people, closer to 5, that are easy bleeders? Okay? You know, you've all heard of hemophilia and Christmas disease and all these other features, or von Willebrand's disease rather, not Christmas disease, but von Willebrand's disease, which people don't clot well. Well, those people don't need to listen to this part about hypercoagulability because they've, got their own personal counter scenario. But 15% of the population approximately are hypercoagulable, meaning there are easy clotters or excess clotters. Now, I'm in that group. I would suggest other people that should worry and think that they might be in that group would be folks with MS, folks with migraine headache, and of course all the consequent issues if you got hypertension and all these other issues, or even obesity. But those folks should worry about the hyperclotability. So if we're going to talk about the hyperclotability, and it's important to talk about it because now when people are sick enough to get admitted to hospital, almost all hospitals will give them a blood thinner when they arrive. They've done, of course, a couple of screening blood tests in the beginning, but they're almost always put on heparin or some other blood thinner for the time that they're in the hospital because it reduces the secondary side effects of the hyperclotability. Remember, brain, kidneys, of course the lungs, and the heart. Because all of these do badly if they get the emboli or clots that find an endpoint in one of those organs because it injures it long term. So my favorite, and I've been on it for about a year now, so I was on it even pre-COVID, is nattokinase. NATTO-KINASE. So that helps the body deal in its regular fashion with fibrin. So fibrin is part of the clotability within the body, but some of us have a little bit of extra fibrin, and if we have a chronic illness, then we typically have extra fibrin, and virtually always when we get a virus, and even worse with COVID than a flu virus, ordinary flu, influenza, that we get that hyperclotability. So I would suggest anybody that's in those groups I've already talked about, as long as they don't have an abnormal bleeding component to the blood, I mean, it isn't going to be lethal for them, but it won't be indicated to take the nattokinase. And it's, that dose twice a day because it only lasts 8-12 hours in the body. And so taking it 100 milligrams twice a day is fairly inexpensive, available over the counter in the health food store and so on, recognized, of course, by Health Canada. They can make some cardiovascular comments with regard to it because it makes some difference to protecting you from that hyperclotability and that injury to your heart, brain, but also probably your kidneys. Yeah.
Yeah, and then serrapeptase is another option.
It is. It's a little harder to get that, and it doesn't have quite as much documentation on the blood thinning. But yes, you need to look at other choices if you're hugely allergic to soy, because natto, of course, comes from a fermented component of soy. Not that I'm crazy about soy, but if you can get organic soy, and there is products out there that are from organic soy, then the protein is reasonably minimized. But if you've got a huge, severe reaction to soy, you need to find other choices. I know that, so the other piece that people might consider in that whole ball of wax is what you might do, for your COVID. And we've talked about that in other considerations, and, we'll be talking about it again. And I know there's a group of physicians about to, hopefully make some comments to bring down, the fear or anxiety around COVID, because everybody's frightened at the moment, and I'm not sure that they need to be. as much. Yeah.
Mhm.
So other components of stroke, do you want to, or even brain recovery post-stroke, do you want to, talk to a few features about it, included within that, anything to bring down the inflammation, whether it's microbiome or otherwise?
I definitely have a fair bit to say about the microbiome, but in terms of post-stroke recovery, I feel like omega-3s would be pretty relevant.
Well, for sure.
Mhm.
So, I used to list about 8 or 10 things that people should take if they're going to try and optimize their health and supplements, but I've reduced that dramatically. So now I talk about vitamin D, at least 4,000 units a day, maybe more if you don't handle it or you're obese or so on, or, you don't absorb it well, because that's a common secondary problem in health well-being. And number two is always omega-3s. So I talk about, 2 to 3 grams per day of EPA plus DHA. And I prefer to get it not from salmon oil, because salmon oil is reasonably contaminated. Most people don't clean it up, for the heavy dioxins or maybe mercury from the oceans. So fish oil is the best documented. Some people will use other features, but the best research is still on fish oils themselves, as far as doing it. So you're right. And I recommend the fish oils because it brings down the inflammation, and that's a big factor. Curiously, it also cuts in half your risk of sudden cardiac death from arrhythmia, because that tells you whether it's from the improved blood flow or the stabilization of membranes or even from the brain recovery, because the brain is a huge amount of omega-3. It's an important piece. And it isn't in my acute treatment of COVID, but I'm on it regularly, and I would like most of you to be on it too.
And then in terms of bringing down oxidative stress, increasing glutathione.
So whichever way you want to improve the glutathione, multiple ways to go at that. There's N-acetylcysteine as far as a supplement. There's a few nutritive routes for that. You can maybe mention some of those, but we need to have more glutathione. And of course, within that whole mix of more glutathione, because your body makes it. It makes it in the liver, makes it in the lungs, makes it in the kidney. Glutathione is our number one so-called detoxifier. It's our number one personally made antioxidant. And of course, the other one that we make a lot of is coenzyme Q10 and alpha lipoic acid, but glutathione is always the number one.
Selenium and vitamin C recycle glutathione, and then I don't know how many of our audience will know this term, but NRF2 activators can also promote the production of glutathione. And the number one NRF2 activator that I know about is sulforaphane from broccoli sprouts.
Yeah, so broccoli sprouts are superb. That's right.
And then in terms of like if someone's doing oxygen, or maybe they can't do oxygen, there is one herb, rhodiola, which evidently increases circulation to the brain.
Well, and it's a popular adaptogen. I mean, we talked a little bit earlier about cortisol, stress factors. Anytime you're increasingly stressed, you're going to have increased problems with stroke risk and any blood vessel problem. Rhodiola, we do know, is an adaptogen, and it helps considerable recovery of the adrenal gland. Okay, so that may optimize people's recovery. If you've already treated, a low thyroid, for example, they're not responding, then we need to start to think of, is the cortisol completely stressed? Because that affects the thyroid, of course, because the high cortisols reduce the transmission of T4 into normal T3 and increases the transmission of T4 into so-called reverse non-active T3 in the body. And so that's why it's tied in, but the secondary corollary might well be rhodiola.
We do have a couple questions. Maybe we can go through those for a minute here. Dr. Code, did you have factor V Leiden testing?
Well, factor V Leiden testing is available in Canada. I don't do it, of course, personally, but I don't do any labs personally. I send people to a lab. And factor V Leiden is the one that's the most commonly associated with young women having a stroke or other indications therein, because it's aggravated by the high estrogen of the oral contraceptive. Okay, so those are tied together. So it can be tested readily in Canada and is tested sometimes when there's one member of the family, because it tends to be genetically transmitted. So then you should test the other people too. And some people are so dramatic with the changes within it that they're on a blood thinner for the rest of their life. Okay. Whereas if it's just kind of a borderline change, you may not need it, but you need to be aware of the things that trigger it and aggravate it. And one would be oral contraception. So you might want to think seriously about another modality.
Okay, next question. What do you think about the upcoming immunization shots for persons with multiple sclerosis that are not on any immunosuppressants, just on supplements like you are mentioning, 10 years post CCSVI?
Sure. So, a good question, and one that I've thought about a lot, of course, having MS myself for 24 years. The initial concept was that it shouldn't make too much difference, but I'm always a bit anxious about the vaccines, and I'm particularly anxious about the one that we're using for COVID because it's made from messenger RNA. And in some people, they won't handle it as well. So my personal suggestion, which I will tend to follow, is I would rather a lot of people had it. So I just read the CDC recommendations for it, for what they're going to do. And this might answer the question for you, because if you're younger, you're going to be further down the list. Now, if you're in a chronic care home facility or a healthcare worker, then you're at the first of the list as far as getting this COVID vaccine, multiple types, as you know. And then number 2 would be the group over 75 years. So if you're not in that group, then you're down to number 3. I'm in that number 3 group because the number 3 group is people over 65. But there will be an ongoing possibility that, well, they're going to give it to a subset of people with certain illnesses. My personal feeling is that I would like a lot of other people to have it first to see, is it going to perhaps aggravate autoimmune diseases? Okay. I know when I went preparation to go to Africa, I needed to have yellow fever, but because I had MS, they said, you get a pass. You don't have to have yellow fever vaccine because it's shown to have some corollary problems in folks with MS, whether it's triggering episodes or whatever, but that's pretty much dogma. So I think you could make a case if you're trying to decide on it, well, maybe I will. And, my personal choice, I've, recently found out that I've had COVID, I have positive antibodies, so it takes away my consideration even further to whether I would do the COVID vaccine. But my personal suggestion, just as I've suggested to a couple of MS patients or clients or friends already, is let's have several million, and in Canada we're 38 million. I'd feel better thinking about a vaccine if 10 million people have already had it and done well with it. Because we will know a lot more, because we're mostly doing the 3rd trial of testing, which is usually done before release to the public. We're doing it right now in the public. Okay, so we're doing that testing and writing down the responses. And so far, it seems about 3% of people respond acutely in a significant way. So that's pretty high. And the second injection might aggravate it even worse. So I want us to be careful, because I want to make sure for people that it's relatively safe and it's been confirmed effective. Because most often they're telling us it will weaken the severity of your COVID, but that's all they're suggesting so far. So a tricky question, and lots of us are going to go through it and ask about it. But if I have MS and younger, so I'm not in the other groups that I just mentioned, I would hurry up and go slow, personally.
Okay. Next question. How much vitamin D can a 6 and 8-year-old take each day?
I typically recommend, once people are over a year old, 2,000 international units per day. And that is known and shown to be very safe. They use it in Finland for 20, 30 years, all the young kids over a year. Unfortunately, I think they've kind of adapted to the North American standard, which isn't great because 40% of us are low vitamin D in Canada and the United States.
Mm-hmm.
Even the southern US, there's lots of people with low vitamin D. Partly it's darkness of skin, but partly it's also putting on sunscreen because adversely blocks it all happening. So I would much rather that they had 2,000 international units a day, particularly important right now. Happily, young children, teenagers, people in their 20s and 30s, almost no serious problem with COVID-19, but the vitamin D is critical for many, many things, and even, during pregnancy, of course. Ideally, the mom breastfeeds, the mom's on vitamin D supplementation, maybe 3,000 or 4,000 international units per day ongoing because of the pregnancy and everything else, but usually at least two, no question. But my personal preference is in pregnancy, people move it up to say 4,000 international units a day because it calms down some of those features and it will enable your child, if you've got a slightly higher vitamin D during the pregnancy, it reduces your child's risk of onset of MS, childhood cancers, and a number of other features because it is so important to optimal health.
Mm-hmm. I did formulate that vitamin D supplement that I was telling you I would with all of the correct cofactors. I kept it low so people could build it up as they wanted. I kept it at 1,000 IUs, and then if someone wants 2,000, they can just take 2. But those should be here in maybe a week or 2.
Sure. And so that has some vitamin K in it as well, right?
Vitamin K, magnesium, a little bit of vitamin A, and I might have even thrown in like zinc or something.
Yeah. Well, and zinc's a really important one in this day and age because any of the things that help us reduce the response to COVID, typically it's allowing more zinc into the cells so that they can reduce the virus repetition or replication. So, and things that do that, that's probably how we're going to learn how, the anti-malarial or other agent for ivermectin works. It is certainly how hydroxychloroquine and quercetin work. I'm very big on quercetin because people can buy it over the counter. There's studies on it happening right now, but it's pretty benign stuff, 500 milligrams twice a day. I would double that if you're experiencing the first sign of COVID and so on. But, so quercetin and taking extra zinc at the same time.
Awesome. Okay, we're through the questions for now, so we can jump back to talking about root causes and reducing the chances of stroke.
Yeah.
I could comment on the microbiome. So in terms of, so we know the microbiome is such a huge mediator of inflammation and genetic expression. So just in general, it's really important to balance your microbiome. But I did look through some research where there were certain signatures and patterns that were connected to atherosclerosis. So for example, part of that signature was low butyrate producers. And we know butyrate is a really important short chain fatty acid. And you get the butyrate from having your microbes ferment fiber into the short chain fatty acid. Another part of that signature was actually high Clostridia, which we did formulate a probiotic for. And then another aspect of that was higher microbes associated with oral dysbiosis.
Well, sure, and that's a piece we've missed, and I'm just working on revisions. We should have the French copy up there within a month, actually. Happily, it's about to be printed. As we did that revision, you helped me put in more about the oral microbiome. It's not very much. Short story is the oral microbiome, meaning the mouth and the nose and so on. It's an important one to think about, even if you're worried about virus infection and so on, because you want to have your own team of bacteria and fungi with you. And so you don't want to burn the living daylights out of all the healthy bacteria in your mouth. And some of you do that every time you use a toothpaste, and almost all the major toothpaste chains still have triclosan in them, triclosan, which is an antibacterial, which is reasonably toxic. In fact, it's been pulled in the US for 2 or 3 years now. And yet, in a lot of our antibacterial things, it's still around, unfortunately, and it's still there in toothpaste. And I'm not huge on fluoride in a toothpaste for the same reason. Each of those entities, and I'm not big on chlorhexidine rinses in your mouth or mouthwashes, because it doesn't just kill the negative bacteria, which is we always thought it was doing in a happy fashion. It kills all of the normal background ones. So the wise people are tending away from toothpaste, and they're using a whisper of maybe sodium bicarbonate or a whisper of salt, or ever so tiny little amounts of toothpaste, for the simple reason it's the brushing and the flossing which is the biggest healthy factor, and not so much the agents that you're putting in with it.
Mm-hmm. Yeah, agreed.
So, the oral microbiome is an important piece. And maybe you could comment too, because I know we're getting more and more wisdom and knowledge from the literature and so on, talking about particular things to use as prebiotics. So what those do, of course, is they allow us to take the bacteria that we already have,
mm-hmm.
but it enhances particular groups of them. And by enhancing that particular group, we've got active, healthy, brand new bacteria, as opposed to a probiotic, which has maybe had millions of generations in it in the preparation so they can make it affordable. And consequently, when we have it, it's lost almost all of its wildness. So that's why the advantage of fermented foods, or as you say, the fermenting that happens within. So maybe you could just talk a little bit about we've been taking them for years, some of them, prebiotics.
Yeah. So usually what I do is I will run a microbiome test on a person and then look for the specific microbes that they need to increase and then recommend a prebiotic based on that. But some of the ones that we might use might be arabinogalactin, which would increase some of the more beneficial species of Prevotella. Sometimes we'll use sun fiber or partially hydrolyzed guar gum, and that one's pretty good for increasing butyrate producers as long as you don't have any within that group that are overly elevated.
So not everybody can walk into a store and ask for those. So which ones could we ask for that would do those things for us?
Sun fiber.
Butyrate producers.
Sun fiber is pretty easy to ask for. It's available even at Superstore. Larch is becoming more common, and larch is arabinogalactin. That's that first one that I was talking about.
Okay.
Algae, interestingly, I haven't looked into how prevalent those are as of yet, but there are certain algae that
we're going through a freeze, aren't we?
Probiotic, so the Saccharomyces boulardii. The cell wall from that is actually a prebiotic. And then the one that I was raving about the other day is lactulose, but you have to get that through either yourself or, I do have sneaky ways of getting it, but you more or less have to get lactulose through a doctor or a naturopath.
And the other one you'd mentioned the other day was lignans, right?
So yeah, lignans as well.
I've always been huge on ground flax, for more omega-3s, but the other advantages within the fiber. And so it's recent to me anyway, finding that the lignans are a particularly good source of fiber. They're in ground flax, especially from organic source, not expensive, but it would be a good reason because it increases particularly, is it lactobacilli or bifidus?
I'm not 100% sure yet, but it's being paired with bifidogenic and lactobacillus promoting substances.
Sure, which are two of our favorite ones to produce. They're common in probiotics for the same reason, but if you can make them fresh or enhance your own small number within you and make it a bigger number, that's a more optimal route, and it tends to be less expensive, but it tends to persist. Unfortunately, virtually all probiotics are gone within 10, 14 days of you stopping taking them because they don't linger they don't persist within the body.
Mm-hmm. And then I think sometimes we forget, but polyphenols are actually prebiotics as well.
Yeah, and polyphenols are all good, whether that's berries or whatever source of polyphenols we're talking about. More fruits and vegetables, because the more different fibers, and my little brain says, the more different fibers you take in by the variety of foods, ideally, as you know, you've talked about the 50 foods per week, then you get those variety of fibers, and each kind of team of bacteria tends to have its own preferred fiber group. So if you're getting a big diversity, you're getting a big diversity in the gut. Every time you increase the big major diversity of bacteria within the gut, you're almost always making the nasty guys a minuscule portion. So then we can tolerate them.
Mm-hmm.
You, even of the nasty Clostridia, is not a problem. It's just when you knock out all the other diverse types, now all of a sudden they can become a problem, whether it's Salmonella, Clostridia, and the list goes on, Shigella, so on.
Mm-hmm. Yeah, and then when we look at something like insulin resistance, that's another group. We don't have enough time, but there is a microbial signature for insulin resistance, and some of the microbes, there's a couple microbes that are deficient with that, and those can be increased by resveratrol for one, which is a really, really great polyphenol.
Yeah. Mm-hmm. Go red wine.
Yeah.
And as you brought up that feature, because we know one other thing enhances the microbiome, and this would enhance stroke recovery, is that little old issue of exercise. Okay, mm-hmm. And when you mentioned insulin resistance, I read a paper this week, which was pretty interesting, because if you can improve your muscle use, and so this might be as simple in a stroke person as going on a vibration machine, okay, mm-hmm. or some other modality of exercise, because as you create more muscle fibers, you all of a sudden now are bringing down your insulin resistance. And insulin resistance is tied in heavily to prediabetes and diabetes. So anytime you're winning in that equation, you're bringing down inflammation. Because remember, the short story is a sugar spike or a simple carbohydrate spike, as in grains or whatever, all of a sudden you get an insulin spike and you get an inflammation spike. Remember, excess inflammation we always don't want.
We forgot to talk about LPS, but LPS is such a strong.
So it's an aggravating factor in microemboli. LPS, of course, is lipopolysaccharide. It's the breakdown product of a gram-negative bacteria in the gut. But if you've got an unhealthy gut and a leaky gut, then LPS gets in and it triggers and aggravates issues, especially in the brain, even probably in things like MS. But it doesn't help stroke either, because you want a healthy endothelium lining of all the blood vessels in the body.
Mm-hmm. Yep.
Oh, we got any more questions, Chief?
No, we don't have any more questions.
Okay. So, we're doing a special discussion next week. So I will be listing on my Facebook, because Christina and I are going to do another presentation next week, which won't be directly through my Facebook, but we'll try to get it available so you could link into it. Do you want to mention that for a minute?
Yes, so we're going to be on a podcast, and he changed the name of the podcast recently, and I can't remember it. I think it might be called...
That's okay. We'll list it on our Facebook site. Yeah.
Yeah, he's usually pretty quick at the editing and upload, so...
Okay. And just so that you know, for any of you that have missed this today, or you know somebody else that missed it, you may be able to find it here, but you can also find it on my website, drbillcoe.com, and there's a link there on Christina's website, mindmoodmicrobes.com, a link over to mine, and then if you look under blog, you can find these listed, and they're not just available in a video via YouTube format, but they're also available in an audio format, and so that you could podcast them audio and take them with you, or send them to a friend, or whichever way you want to do it. And those are at no cost.
We actually have one more question that just came in. She's asking, my husband is getting his COVID immunization as a frontline worker. If I don't take it with him, am I at risk of getting COVID from him? And then I want to know if she is she still at risk from getting it from him because of the shedding?
I don't think the best evidence is that the vaccine gives you COVID per se. Okay.
Mm-hmm.
So I think your risk of COVID from your partner, as far as just the injection itself, isn't very dramatic. Okay.
Mm-hmm.
Or virtually not at all. Your partner being still in the frontline system, because remember, you're staying with the vaccine, it may reduce the severity of your illness with COVID. It may not guarantee that you don't get it. All right.
Mm-hmm.
So those are two different things. So it's not going to make your risk zero, but I don't think it's going to increase your individual risk.
Okay. Yes, we don't think shedding is an issue.
I don't think shedding is a major feature. But keep yourself healthy,
Mm-hmm.
lots of vitamin D, have your vitamin C with you, have your extra quercetin and zinc on hand. To treat that, you may need a secondary antibiotic. It's interesting, in India, they provide them kits with doxycycline in it.
Mm-hmm.
The early one that we were using that I would tend to reach for is azithromycin, which is an antibiotic we've had for a very long time. And that's because of the secondary bacterial infection some of us get in our upper airway and throat. Yeah. So a good question, and we're going to get more of that consideration now because
Mm-hmm.
that the vaccine is being used throughout the planet now.
Mm-hmm. Arlene is asking, can I expand upon the resveratrol in the diabetes? Resveratrol can be used to grow some of the microbes that help with insulin sensitivity. And there are other things that do this as well, like pomegranate. It just depends on what your microbiome balance is like. But when we look at the research and we see that overall, if we look at the general population who have diabetes, the signature of that tends to be that these people are deficient in these certain microbes, and resveratrol is one of the things that can be used to grow them.
But remember, also the other polyphenols
Mm-hmm.
are incredibly useful too. So we've never done a wise job when we've focused on one or two, supplemental things that we take out of the fruit or take out of the vegetable and give it to us. We have always done better if we take in the whole fruit or the whole vegetable in some various shape or form, because then it's got its unique polyphenols in it, and there's several hundred. Okay, it's got its unique polyphenols and sometimes its unique fiber as well.
Mm-hmm.
Okay.
Okay, that's all the
So I
questions.
think that pretty much wraps it up. I think we'll be at it probably in 2 weeks today, because the end of next week is when this, specialty item's coming up. So we'll list that on my Facebook page. You folks can have a look at it. Please share this with others if you wish, and we'll look forward to talking to you again.